I am an otolaryngologist, an ENT surgeon. I've been trained in India, and I have worked in India before coming to WHO. I was working as a professor of otolaryngology in one of the leading medical colleges in New Delhi, the Maulana Azad Medical College. So I was working there as a clinician, as a professor, but also working with the government of India to develop national strategy for hearing care in India. Besides my master's in otolaryngology, I also I have done a PhD in public health in India itself, and I've been involved also with WHO before coming here, WHO in the Southeast Asia region, and an organization which WHO Southeast Asia region had set up, which is called Sound Hearing 2030. So I was involved with this organization, and through this organization also working in some of the other countries of that region to help them to develop their, or to support them rather, in developing their hearing care strategies. Okay. So that was what I was doing prior to my new life in WHO. I joined WHO in December 2011, so just a little less than 3.5 years ago. It is called the WHO Program for Prevention of Deafness and Hearing Loss. The program itself is over 50 or maybe 20 years old, but it has not had a very stable existence. So the program ran for about 12 years, then there was a gap for a few years, then somebody worked again for 2 years, and again there was a gap. So the program has now been restarted since 2011 December, when I joined and the new position was created, and we are trying now to take this program, give it a new shape and a new life, involving all stakeholders, building upon what was already done in the past, in those 12 years when the program was running. There were a lot of outcomes we developed, a lot of materials were developed. So building on that material and trying to engage with all stakeholders, so that in the context of new developments which have occurred in this period of time, we're trying to take this program forward with the vision that we would one day have hearing care strategies in all countries in the world, which would take care in terms of preventive care, but also identification of hearing loss, treatment of hearing loss, rehabilitation, social support, down to the community level. Many activities had occurred before I came. There was in 1995 there was a resolution in the World Health Assembly. World Health Assembly is the platform where all the countries, the 194 countries which are WHO's member states, they come together to decide what are key issues, what issues need to be addressed, and how. So in 1995, the World Health Assembly had passed a resolution saying that hearing loss is important and actions should be taken to address it. Following that, WHO had undertaken quite a bit of work. We developed training resources to promote hearing care at the country level. There were guidelines were developed for fitting of hearing aids in the lower and middle income countries of the world. Also, there was work done on otitis media, discharging ear, which is a very common problem in the lower and middle income countries of the world, especially in the tropical regions. Then also work was done, some work on occupational noise exposure, on hearing loss which is caused due to ototoxic medicines. So a lot of work was done in this 12 years, and now we are trying to use that, but to try also update it, because, well, things become outdated in the scientific world fairly quickly. So we need to update those materials which had been created at that time, which is a resource to countries, but at the same time also to take it down to the country by interacting with the countries, with the ministries of health, and supporting them in the development, as I said, of strategies which can actually use those tools at the grassroots level. So at the technical level, I work on this program alone.
Okay.
But I have my supervisor and my director who support me in this work, and we brainstorm together and decide what is the direction we are going to allow this program to take. So that is the team in the WHO headquarters. We are 3 of us, and then because WHO has 6 regions across the world, mm-hmm. and in each of these regions it has an office. So we have 6 regional offices. In 5 of those 6 regional offices, we have a person who looks after different areas of work, but also deafness, not exclusively, but as part of their other activities. They may be looking after blindness and deafness, or at times disability, or at times violence prevention. So different areas of work, but we work with them to promote our strategies in the regions and then the countries of that region. So typically WHO works with governments. Mm-hmm. It works through the ministries of health, and through ministries of health it may work with other governmental departments as well. But typically it works with the governments. Let me just take you a step further. We have the regional offices, which I told you, but we also have in about 145 of our member states, we have country offices. Mm-hmm. So there is a structure existing in most of the countries which interacts directly with the ministries of health in that country. So typically WHO works through the ministries of health. Having said that, when we develop strategies in a particular country, it is also important for us to engage with the private sector, who are often very active, sometimes more resourceful than a government can be at times. So it is certainly, we try to bring all stakeholders on board. So for example, if we are working in a particular country or supporting them in the strategy development, we would look at who all are the stakeholders in that particular country. There would be some NGOs who are already working in the field of hearing in that. There may be other potential NGOs who could work in the field of hearing care. There would be certain agencies, maybe some very strong commercial entities, those who provide hearing devices or cochlear implants. So so we try to get all of them on board in order to develop a strategy which takes all points of views into consideration and which also has ownership of everybody. So in a short answer to your question is that WHO works with the ministries of health, not through private partners. But at the same time, it is not that we cannot partner with anybody other than the governments, but traditionally our partners in countries, especially for our work in countries, are governments. Let me try and just describe for you what WHO does in the field. What does the Program for Prevention of Deafness and Hearing Loss do? So we have two main areas of work. One area of work is advocacy, and the second area of work is technical support. So if we look at advocacy, what do we mean? So when we say advocacy, the purpose of advocacy is to raise awareness about hearing loss, about the causes, the impact, the prevalence, the prevention, etc. of hearing loss at all levels. So at global level, but also within the countries, and also going down to the community level. So it is important for us also to address all levels, including the individual level. So how do we do that? We do that through development of tools and messages. For example, and the tools and messages have to be evidence-based. So a lot of work needs to go into the development of those tools, because often each and every statement which is put out by WHO would have a lot of work behind it in order to validate that information. So advocacy, which is evidence-based advocacy, and that includes release of data such as the estimates. You may have seen that 360 million live with hearing loss, so on and so forth, or 1.1 billion are at risk. So all that data, but also messages, make listening safe. What are that hearing loss or ear care can avoid hearing loss. So those kind of messages which are evidence-based. So we develop those key messages and try to spread them at the various levels. So targeting different people or different sections of the society. It may be press or media is one where we would do press releases using the WHO communication channels. But at the same time, we may send out some information to the countries, and also develop materials which would be used by end users, by individuals, in order to understand what we are talking about. It may be social media outreach, where we can address or even we even do like question and answer responses to individuals in order to address or in order to raise awareness at all levels. So advocacy is one very important part of our work. The second part is technical support. And when we say technical support, again, we mean two things. So in technical support, there are two aspects. One is to develop, again, evidence-based tools of technical support. So what is a tool of technical support? For example, is some recommendations about recommendations about infant hearing screening. So what is the process of infant hearing screening? What is the need to address it? How it can be done? What are the common practices in the world? So we have, for example, a document about that. Then we have the training resources. So training manuals for different levels of workers within the health system to train them about hearing care. So these are tools which I'm just giving you, these were a few examples. So these are some of the tools which countries can use when they're developing their programs or implementing them. And then the second part of the technical support is a more individualized assistance to countries when they are in the process of developing their hearing care strategies. So we try to support them or assist them in undertaking a situation analysis, in developing their strategies, studying the health systems, sharing practices from different parts of the world, helping or supporting them in finding what could be the best fit for that particular situation, also in monitoring and evaluation. So that is a more hands-on and personalized support to the country. So these are the two key areas of work: advocacy and technical support. This is Écoute sans risque, or Make Listening Safe. So this is an example of an advocacy campaign or initiative that we have launched. So essentially this issue, because it is an issue which, in the context of hearing loss, in the various causes, recreational noise was one we have not really addressed, and that's why it was decided to address this issue. And we know that hearing loss due to noise is completely preventable, and in order to prevent it, the most important thing is to be aware. So the awareness has to be raised at a global level, also at the level of all the stakeholders, whether it's governments, it's manufacturers, it's parents of children, it's people themselves who use these devices. So with that aim in mind, we developed this campaign, developing certain messages which would, and we also tried to package these messages in different ways in order to reach the different audiences, you could say. So through our media outreach and through the press releases, our intention was to reach, through the media, the governments, and also all stakeholders in general. But we developed this document in order which we could send out, which is it's basically detailing what the issue is, what can be done, what is being done to address it, how it can be addressed, and it has action points for different, what can governments do, what can manufacturers do, etc., etc. So it's for policymakers, for people who are in a position to make a change. But then we also developed materials which could target the individual user. For example, a flyer like this. We also have some other materials where we could kind of tell them that, okay, this is what can happen and this is what you can do. So messages which are tailored to the individual. So therefore yes, this is an example of an advocacy campaign which WHO launched in order to draw attention towards hearing loss in general, but also specifically the issue of hearing loss which is caused due to recreational noise exposure. The 3rd of March is it's called the International Ear Care Day, and the purpose of that day is only to use it again. It's an advocacy tool whereby we can promote a message on that particular day. So if by having one day in which people across the world, countries across the world can focus on the issue of hearing, we have tried to create some global momentum to in order to raise awareness about hearing. So the 3rd March is again an advocacy tool which WHO used. For example, this year on 3rd March we launched the Make Listening Safe initiative. Last year we had another theme which we promoted using various channels, various materials which we created. But also the countries can use the day themselves. Professionals within the countries often, we have many examples where they use this day to also lobby with their own policymakers and governments about hearing loss and about the need to address the issue of hearing loss. Also, it is used by some partners to just as an opportunity to create some awareness within their communities. So the levels of actions which can occur on this day or which occur on this day, they vary from place to place. At some place it may be national level action, or some national level event may be there. At some places it may be a local or a community level event. It doesn't matter. The point is that we have a day which we can use in order to promote hearing health messages. So it's a common platform for people across the world, and something which, and WHO creates a message which the people across the world can use if they wish, but it's only an aid. WHO's message is only a kind of to give them a talking point, to give them some information, but people across the world who are working in this field of hearing care are free to use this day as they want to in order to promote any message about hearing care which they deem fit in their community, in their the particular area where they're working. This day was actually announced as part of the first first conference on prevention and rehabilitation of hearing loss. This was held in 2007 in Beijing, and one of the outcomes of this conference, which was it was a collaborative effort between WHO and our partners in China, the Chinese Deaf People's Federation. So it was a joint effort between them, and the outcome, one of the outcomes of this was the Beijing Declaration, and the Ear Care Day was designated as part of this declaration, and the dates of 3rd March were chosen because of the similarity of the figure 3 to the years. This year we have had about 30 countries or so which I know of, or who have reported back to WHO about efforts which they have made or activities which they have undertaken. It's not a simple question with a straightforward answer. Whether governments like to work with WHO, well, yes, most governments recognize that WHO is the world's, health agency, but they do liaise very closely with WHO. Like I told you, we have offices in 145 or so countries, and they work very closely with the ministries of health. However, having said that, WHO's role is typically to support countries in the work they want to do, and provide them with the tools and assistance in doing the work which they want to do. WHO's mandate is set by what the governments want to do. So working with governments is not always easy, because working with governments is often slow, but it is also, the good part of it is that it is also often much more sustainable than working with private partners. So one may create or kind of have a project in a country which is supported by private agencies vis-a-vis a program which is created and supported by the government. Well, the government program has usually a much longer lifespan and sustainability, better sustainability. So it can be slow at times. At times it can be frustrating, because sometimes governments change, and when the governments change, the priorities may also change. Their focus shifts. But so at times things don't work out as easily as they would if it was just a private agency. But having said that, WHO's mandate is to work with governments, and we find that even though it may be slow, but it is much more rewarding in the long run to work with and through the governments. Also, one very big strength, I would say, of working with the governments, when we work with the ministries of health, but it also gives us access often to other departments which are working, because while WHO works with ministries of health, but any such health issue, whether it's hearing loss, vision, physical disability, it's not just a health issue. There are also other matters related to it. It may be about education, it may be employment, it may be captioning services, sign language. So there are various other departments which also feed into it, or other groups which should be involved in the effort for hearing care. And working with the governments allows you to at least have that access to these other departments and perhaps influence or make a change, not just at the action level, but at a policy level. So in France, our contact is with Agir pour l'audition, which we have recently made not too long back. Also with the French Society for Otolaryngologists and the International Federation of Otolaryngology Society, because the president of this society is of this association is right now currently a French otolaryngologist. So our collaboration in France is mainly with these two bodies. The French Society of ORL have been part of our meetings and efforts to create more awareness, but also of our technical groups. And Agir pour l'audition, so we are now developing our relationship in order to promote our common, areas of working in terms of prevention of hearing loss, of noise-induced hearing loss, and other messages in France through the platform of Agir pour l'audition. We are still working on some potential projects, and we haven't really finalized anything about that. So I think we'll have to wait to see how things evolve and give you an update maybe in a few months' time. In 2012, WHO developed some estimates about how many people possibly have hearing loss. We do develop these estimates from time to time. 2012, the figure was 360 million. 32 million of these are children. Now, as per our how the status of hearing care is across the world, it is very variable. We know that majority of people who have hearing loss live in parts in the underdeveloped parts of the world, in the low and the middle income countries of the world, as compared to the higher income countries of the world. Last year, WHO released a report where we tried to assess what is the capacity of countries across the world to provide hearing care. So when we say assessment of capacity, we mean what is the human resource available, do they have any strategies to address hearing loss, so on and so forth. So what we found was that the capacity in terms of human resources, in terms of availability of educational facilities for hearing loss, to address hearing loss, was the least in those parts of the world where it is most needed. So the areas of maximum need had the least resources. So there is no uniformity in how hearing care is across the world. There are parts of the world, there are countries which have excellent, very well established hearing care programs where the high-end technologies are provided to people either through insurance or at no cost to them for hearing care. Surgical facilities are available, so the rehabilitation is strategies are well established. There are other support services, whether it's captioning, sign language, are very strong in these countries. But at the same time, there are other countries in the world where these facilities are still very, very rudimentary, where one otolaryngologist for let's say a population of 4 million people, you have one otolaryngologist and no audiologist. So that situation exists. So there is no uniformity in how hearing care is being made available in different parts of the world. So just to tell you what that translates into in real life. So let's say a child is born deaf, okay, in any, let's say France, okay. It's quite possible that by the age of 6 months, this child would have been diagnosed, either fitted with a device or at least be in therapy. So once that is so, the child or the child would be in terms of rehabilitation for sign language. So whatever it is, the child has been identified. Either he has been fitted with a hearing device, which is a hearing aid or a cochlear implant, or the child is learning communication through sign language and therefore able to, access education and thereafter, later on, of course, employment. Now, look at a similar situation, let's say, in a rural area of a middle income or a low income country of the world. You have a child who's born with hearing loss. Well, a year goes by and then the parents start thinking, maybe something is wrong, maybe he's not hearing well. Then they take the child to a local practitioner who may tell them that, it'll be okay, it's fine, just wait for a few months or a year or so. By the time the child is diagnosed with hearing loss, he's already 3 years, and even after that, there is neither access to sign language education nor to devices. So it may be another 3, 4, or 5 years by the time the child even starts getting any rehabilitation. So a child who is getting rehabilitation at 6 months versus a child who's getting rehabilitation at 6 years, there is really no comparison in the outcomes in terms of their education, in terms of their future livelihood. So what I'm trying to showcase is that the situation in different parts of the world is very variable. So there is no consistency in how hearing care exists right now in different parts of the world. We don't need, therefore, to compare with other programs, because we can compare hearing care in one part of the world with hearing care in the other.